1, 2, 3. Present.
Good morning, everyone. Selamat pagi semuanya. Ohayo gozaimasu. I hope everyone is in healthy and happy condition today. Welcome to this international guest lecture. The theme of this guest lecture is role of genetics in neurology disease. And this guest lecture is presented by Department of Neurology and Anatomical Pathology, supported by guest lecturer and visiting Professor Grant from Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. Welcome to all speakers, Professor Masafumi Matsuo, Dr. Atitya Fithri Khairani, and Dr. Rusdy Ghazali Malueka. Also welcome to all audience in this international guest lecture. Thank you so much for your participation. Ladies and gentlemen, I will inform you the schedule of today's lecture. So first session will be delivered by Professor Masafumi Matsuo. The lecture will be the genetic and management of Duchenne muscular dystrophy. Second session will be delivered by Dr. Atitya Fithri Khairani. She will talk regarding the genetic of epilepsy. And the third session will be delivered by Dr. Rusdy. He will share his knowledge about genetic of brain tumors. And then we will have discussion sessions around 1 hour. And I encourage you and invite you to put your questions in this chat room of the Zoom meeting. And then there are some rules for this international guest lectures. We encourage you to set up your Zoom name with following format: institution dash your full name. And then if you have questions, please put on the chat room and with the following format: nickname dash speaker dash questions. And then the question will be read and answered during the discussion sessions. And we also will give e-certificate to all audience. That's why we encourage you to fill the attendance forms that will be shared in the chat room letters during this guest lecture sessions. Okay, well, before we start our guest lectures, allow me to introduce myself. My name is Eri. I'm a pathologist. I will stay by your side this whole time to navigate these international guest lectures. For the first speaker, it will be Professor Masafumi Matsuo. He's an emeritus professor of Kobe University. He was a professor in pediatric Kobe University in 2003 until 2011, and also Dr. honoris causa in our university, Gadjah Mada. He's currently a professor in the Faculty of Rehabilitation, Kobe Gakuin University, and he's a leading researcher in Duchenne muscular dystrophy with 334 publications, and also its index of 40. That is really incredible. Okay, Professor Matsuo, we will give time to you. You will have around 30 minutes for your presentations. Thank you, Professor Masafumi Matsuo.
Okay.
Yes.
You can start your slide share, Sensei.
Can you hear me?
Yes, we can hear you clearly, Sensei.
I can hear you.
You can start your sharing your screen.
Thank you for the introduction. I'm Masafumi Matsuo, Kobe Gakuin University. First of all, I want to thank Dr. Rusdy for invitation to this interesting meeting. This slide shows a night view of Kobe.
Sorry, Sensei, we haven't seen your slide yet.
Pardon me?
We haven't seen your slide yet, Sensei.
I cannot hear you.
We cannot see your slides yet, Sensei.
Slide.
Yeah, we cannot see your slide. Can you please repeat, share your screen, Sensei?
Why not? あ、そうか。
Yes.
Sorry.
Yeah.
ちょっと待って、wait a minute. そうか。これの、
Okay, we can see it. Can you please slideshow?
これ、it's okay か。
Yes, we can see it. Can you please press slideshow, Sensei?
Okay.
Yes.
Thank you, Sensei.
Yes, it's okay, Prof.
Move it.
Yes.
Okay.
Okay.
Sorry. Okay, I'll repeat again. Good morning, and thank you very much for kind introduction. And I am Matsuo, Gakuin University. And first of all, I would want to thank Dr. Rusdy for invitation to this lecture. This slide shows another view of Kobe, having a red tower in the middle. So it's called Port Tower. The title of my talk today is Genetics in Management of Duchenne Muscular Dystrophy. It's a great pleasure to give a talk in this lecture because I was awarded Dr. Honoris Causa from Gajah University in 2003. Beside me, Professor Purnomo is standing. I deeply appreciate his contribution to my study. Unfortunately, he passed away. I would like to express my sincere sympathies over the loss of Professor Purnomo. By the way, I assume it's hot in Jakarta. Then I will invite you to cool Japan in the next slide. This picture shows a cosmos field. Cosmos is described Akisakura in Japanese. That means cherry blossom in autumn. So please enjoy these flowers. What I'm going to tell you about is Duchenne muscular dystrophy. This slide shows Dr. Duchenne, a French neurologist. In 1986, he was the first to extensively describe the progressive and destructive neuromuscular disorder, now known as Duchenne muscular dystrophy, DMD. This slide shows a schematic sketch of a DMD patient described by Dr. Duchenne. The patient is a boy and shows lordosis and shoulder hypertrophy. Shoulder hypertrophy is an enlargement of calf muscle, though muscle strength is weak. This is one of the characteristics of DMD. And this sketch is true even now. Therefore, DMD is defined as a disease characterized by muscle weakness with infantile onset, progressive muscle wasting, affecting 1 in every 3,500 males, and early death. And this slide shows the progression of DMD. In their young age, they look healthy, but they lose independent walking until the age of 0. Thereafter, they suffer from respiratory or cardiac failure. They mostly pass away before the age of 30. Therefore, it is very urgent to establish a treatment for the DMD. In the next slide, I will show you keys to diagnose DMD in clinical practice. When DMD should be suspected, firstly, muscle weakness in infant. Muscle weakness is revealed by late independent walking, no run, no jump, or difficulty in climbing upstairs. And secondary, hyper-AST-ALT-anemia. This is elevation of aspartate aminotransferase AST and alanine aminotransferase levels. So if you find this abnormality in the patient, please take the DMD into differential diagnosis. This slide shows the Gowers maneuver. This is a typical sign of muscle weakness, and all DMD patients show this maneuver. The patient has a difficulty in standing up from the floor. He needs a support of hand to extend his body. However, this sign appears late. So it's a suggestion to diagnose before this sign appears. Then how can we diagnose DMD in early stage? So this hyper-AST-anemia is important to diagnose early. So to convince you to understand this importance, I will show you one case. An 8-month-old male has AST-ALT elevation. This is as described here. And all of you think that this suggests a kind of liver disease. But our diagnosis is the Duchenne muscular dystrophy. Why? Because we determined his serum creatine kinase. It is more than 40,000. So this is a clear marker to diagnose DMD. So in the case of you suspected liver disease, please measure serum creatine kinase. This slide shows the level of serum creatine kinase in DMD patients. So normal level is below 200 IU per liter. So at all ages, the CK level is high, especially in the infantile period. The level is more than 100 times. So it's easy to the DMD if you determine serum creatine kinase. The next subject is genetics. So I will show you one pedigree of inheritance family of DMD. So everybody can understand that all patients are male. This indicates that inherited pattern is X-linked recessive. So we suspect that genes responsible for damage is present in the X chromosome. And in 1987, DMD gene was cloned or responsive gene or Duchenne muscular dystrophy. It's mapped on P21.2, and DMD is more than 2,000 kb, consisting of 79 exons. But DMD CAD is only 14 kb. This means more than 90% of gene is intron. By cloning the DMD gene, we start to dance DMD in genetic level. Gene diagnosis DMD now can be done MLPA, which is an abbreviation of multiplex ligation dependent probe amplification. This slide shows the basic principle of MLPA. Principle is the PCR amplification of DNA. In the case of the DMD gene, the gene has 79 exons. So we need to examine the 79 exons by PCR. MLPA use only 2 PCR reactions to examine 79 exons. And by that, we can diagnose exon deletion in DMD case. We know that exon deletion is the most common mutation in the DMD. For example, this patient has a deletion of exon 45. If exon 45 is deleted, dystrophin deficiency is produced in his skeletal muscle. In normal, dystrophin stands as like this one. You can see green signal along the membrane. This is the normal dystrophin. In contrast, no green signal along the muscle membrane is seen in DMD. So we say DMD is dystrophin deficient disease. Before I define Duchenne muscular dystrophy as this, currently we must add 2. That one is mutation in the DMD gene, and another one is dystrophin deficiency. So currently, DMD defined like this. So by benefit of gene diagnosis, we know this. At the same time, another type of muscular dystrophy known as Becker muscular dystrophy. This is characterized by adult onset muscle weakness and progressive muscle wasting. Remarkably enough, we know DMD patient has mutation in the DMD gene. And also, they have dystrophin abnormality. So these 2 diseases are allelic disease. But phenotypically, DMD and the BMD are quite different. On the right side, this BMD patient can play tennis. At the same age, DMD patient is wheelchair bound. So when we study the dystrophy in the skeletal muscle, we know DMD patient have expression of the dystrophy, but compared to normal, this is abnormally stained. This is due to the structure of dystrophin produced in the patient. Normally, whole domain are present, but in the case of the BMD, the rod domain is shortened, maintaining the either end of terminal. But in the case of DMD, they have no dystrophy because of the deficiency of C-terminal. This is the structural difference in dystrophy in DMD, BMD. So next, I would like to explain the molecular difference between DMD and BMD. This is important to understand the treatment. So I'll give you the one question. Can you translate the G's?
The dog
Okay.
can run and eat, Sensei.
Okay, everybody can translate G's. It's easy, but this is dependent on the depend on the principle of genetic information flow from gene to protein. Genetic information transmitted from gene through mRNA and to protein by the action of transcription and splicing and translation. At the step of translation, mRNA translated into protein by the codon. So this letter can be translated into the dog can run and eat. Based on this, I can explain what's the difference between DMD and BMD. In normal, the dog can run and eat is a translated one. But in the case of DMD, deletion, R is deleted. Then we cannot translate. This is so-called out-of-home mutation. In contrast, in the case of BMD, deletion is also present, but we can translate. The dog can eat. This is so-called in-frame mutation. This is the difference at the molecular level between DMD and BMD. To summarize that's the result, this DMD patient has only exon 45 deletion, but delayed 176 nuclear deleting. This provides out-of-frame mutation. In contrast, this BMD patient delayed more exons from 45 to 51, but the nucleotide is in frame, then he can express dystrophy. This is called leading frame rule to differentiate DMD and BMD. And another point I would like to explain the importance of this difference, because even though that large deletion can be a milder phenotype than small deletion. So in the next step, I would like to explain the way to what the treatment DMD to expand the deletion. That is called antisense oligonucleotide ASO mediated exon skipping therapy. We proposed that in 1985. the principle of estimate exon skipping that is shown here. This pre-mRNA is spliced to produce mRNA. In this case, the red exon is present. So this is out of frame and cannot produce dystrophy. But using antisense oligonucleotide ASO, we can remove red exon from mRNA. This is called exon skipping. The resultant mRNA recovers leading frame, and so this mRNA can produce dystrophin. This cartoon explains how exon skipping work for the treatment of the DMD. This dystrophin encoded 79 exons. In short, the structure of CDN is described here. Before pre-treatment, exon is deleted. And in this case, the coupler cannot work to join the trains. By ASO-based exon skipping, we remove one train, one exon. Then the train, the coupler becomes smooth, and the train restart to produce, to run. That's made the production of the dystrophin. This is the principle of exon skipping therapy. And 2016, one ASO to skip exon was approved by FDA. At that time, Yang et al. Summarized the history of event in development of antisense oligonucleotide mediated exon skipping therapy. Genes cloned in 1978. Please pay attention to this event. In 1996, first dimension exon skipping for Duchenne is designed. This work was done by Dr. Pramono. He published this paper, Induction of the Exon or Dystrophin transcript. This is the part to induce exon skipping in the DMD gene, and this promoted the many studies in the world. And finally, for ASO got approval from the authorities, and one is under study in phase 1-2 study. As well here, the exon skipping therapy is the standard treatment for DMD, and I think that more ASOs will be developed to treat more DMD patients in the future. I appreciate my all Indonesian students and also the Japanese colleagues. Thank you for your attention.
Thank you very much.
Thank you very much, Sensei, for the very comprehensive and excellent presentation regarding management of Duchenne muscular dystrophy. We will have discussion session in the end, Prof. So we will have another speaker to give their lecture first. And I remind you, all the participants, that you can put your questions in chat room, and then later we will read and discuss in discussion session. Okay, we'll go to the second speaker. It will be delivered by Dr. Atitya Fithri Khairani, M.Sc. Specialist Neurology Consultant. She's a lecturer and researcher in Department of Neurology, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. She's also a neurology consultant in epilepsy in Sardjito General Hospital. She completed her medical doctor in 2006 and completed her a specialist in 2012, and recently in 2021 she received her consultant in epilepsy by Indonesian College of Neurology. Please, Dr. Atitya, you have 30 minutes for your presentation. Silahkan, Dr. Tia.
Thank you, Dr. Eri. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Apakah sudah terlihat, Dr. Eri?
Sampun ya, mungkin di slide show. Ya, sudah terlihat.
Good morning, the honorable of the speakers and moderator, Prof. Matsuo, Dr. Rusdy, and Dr. Eri, and all attendants and the college. Thank you for the opportunity and chance for me. Excuse me, Prof. Matsuo, I will speak in a presentation in bahasa. Baik, di sini kami akan mempresentasikan tentang genetik epilepsi. Jadi epilepsi ini yang kita ketahui merupakan kelainan neurologis yang cukup banyak diderita, baik itu di dunia maupun di negara-negara lain dan di Indonesia. Etiologi epilepsi sendiri dibagi menjadi 3, yaitu epilepsi simptomatik, epilepsi kriptogenik, dan epilepsi idiopatik. Nah, epilepsi idiopatik sendiri memang dikatakan peran genetik sangat besar, sedangkan epilepsi simptomatik biasanya karena ada lesi struktural di otak, dan epilepsi kriptogenik etiologi masih belum diketahui, akan tetapi dikatakan ini berhubungan erat dengan genetik. Jadi ini adalah gambaran etiologi epilepsi yang diketahui pada tahun 1975, di mana sebagian besar adalah idiopatik atau tidak diketahui, dan penyebab lain seperti trauma, stroke, infeksi, dan lain sebagainya. Nah, setelah tahun 2014 sedikit berubah, di mana sudah ditemukan MRI, di mana pasien dengan vokal epilepsi dapat dideteksi dengan lesinya dengan MRI. Beberapa terdeteksi pada MRI. Akan tetapi sebagian besar ternyata juga disebabkan karena kelainan genetik. Jadi semakin berkembangnya waktu, banyak gen yang ditemukan berkaitan dengan epilepsi genetik ini. Ini adalah gambaran, jadi sebagai gambaran epilepsi yang didapat atau epilepsi karena simptomatik di sini cukup tinggi, menempati posisi nomor 2, disebabkan karena trauma, hipoksia, dan vaskular. Kemudian yang terakhir yaitu epilepsi genetik yang disebabkan karena single gen, dan yang paling tinggi adalah epilepsi yang disebabkan karena poligenik. Jadi kelainan genetik ini pada epilepsi dibagi menjadi 5, yaitu single gen atau Mendelian disorder, yaitu satu gen dapat menyebabkan epilepsi. Kemudian yang kedua adalah multifaktorial complex disorder, jadi ada beberapa gen atau pengaruh lingkungan juga yang dapat menyebabkan fenotip epilepsi. Kemudian yang ketiga adalah mitochondrial disorder, yang keempat adalah chromosomal disorder, dan yang kelima adalah epigenetic disorder. Kita akan membahas 1 sampai 4. Jadi di sini adalah single gen atau Mendelian disorder, yaitu satu gen saja tetapi dapat menyebabkan fenotip, sudah dapat menimbulkan fenotip. Nah, ini sangat berhubungan dengan keluarga, dan sangat berhubungan dan diturunkan melalui keluarga. Jadi di sini ada beberapa macam, yaitu yang pertama adalah ion channel implicated in human epilepsy. Ini ada 3, dibagi menjadi 3, yaitu yang autosomal dominan, nanti akan dijelaskan di bawah. Kemudian yang sporadik, seperti yang ketahui ini cukup berat, yaitu severe myoclonic epilepsy of infancy, dan yang ketiga adalah ada ion channel gen implicated in epilepsy. Contohnya adalah pada episodic ataxia tipe 1 dan tipe 2. Kemudian yang kedua yaitu single non-ion channel gen mutation implicated in human epilepsy, yaitu contohnya adalah progressive myoclonic epilepsy (PME) dan ADPE-AD. Kemudian yang ketiga adalah single gen mutation with high risk of developing epilepsy. Nah, kita membahas yang pertama, yaitu ion channel implicated in human epilepsy yang autosomal dominan, yaitu diturunkan secara autosomal dominan. Contohnya yang pertama adalah ADNFLA, yaitu autosomal dominan nocturnal frontal lobe epilepsy. Karakteristiknya adalah munculnya saat childhood, bentuknya adalah motor dominan, bisa dengan gejala hiperkinetik, kemudian timbulnya saat malam, saat tidur, dan bentuknya adalah vokal. Di sini gen yang berperan adalah CHRNA4. Kemudian yang kedua adalah benign familial neonatal convulsion atau BFNP. Ini cukup jarang diturunkan juga secara autosomal dominan. Kemudian bentuk kejangnya adalah multivokal dan general seizure. Jadi ini dimulai pada bayi beberapa hari sampai 3 bulan. Beberapa pasien dapat menetap kejangnya dapat menetap di kemudian hari. Di sini gen yang berperan adalah KCNQ2, di mana ini mengkode dari channel potasium. Seperti yang kita ketahui, kalium berperan pada depolarisasi sehingga akan mempengaruhi depolarisasi sehingga akan terjadi depolarisasi yang lebih lama. Kemudian yang ketiga yang cukup sering terdengar yaitu generalized epilepsy with febrile seizure plus atau Sp.S. Jadi ini ada pasien dengan kejang demam dengan usia yang lebih dari 6 tahun dan juga dapat disertai atau kejang tanpa demam. Jadi ini bentuk kejangnya bisa atonik, bisa mioklonik, bisa absent, dan bisa tonik-klonik. Pada pasien GF+ ini intelijensinya normal, kemudian pemeriksaan neurologisnya juga normal, imaging MRI atau brain-nya adalah normal. Nah, ini yang berperan adalah gen SCN1A, di mana ini akan mengkode sodium channel. Nah, seperti kita ketahui, natrium channel berperan, SCN ini berperan pada inisiasi dari potensial aksi, di mana itu akan mempengaruhi depolarisasi. Pada kelainan pada SCN1A ini akan menyebabkan delay channel inactivation pada GF+ ini, sehingga inaktivasinya atau fase istirahatnya delay, terlambat, sehingga terjadi depolarisasi yang berlebihan. Yaitu juvenile myoclonic epilepsy atau JME. Ini sering pada adolescent, usia antara 12 sampai 18 tahun. Sindrom ini khas yaitu ada myoclonic jerk, terutama pada saat bangun tidur atau setelahnya, tidak lama setelah bangun tidur. Biasanya yang terkena myoclonicnya adalah shoulder dan bahu dan lengannya. Jadi seperti biasanya sering dikeluhkan pasien ketika gosok gigi, sikat giginya terlempar. Ini adalah salah satu bentuk myoclonic seizure. Bentuk lainnya adalah bisa tonic-clonic dan ada absence. Nah, sebagian besar pasien memiliki riwayat keluarga dengan epilepsi. Ini MC-nya genetik yang berperan adalah GABRA1 yang cukup terkenal, yaitu yang untuk mengkode gamma aminobutyric receptor, di mana GABA ini berperan pada inhibisi, sehingga ketika terjadi kelainan pada GABA ini akan terjadi kejang juvenile myoclonic epilepsy. Kemudian yang kelima adalah autosomal dominan idiopathic generalized epilepsy, di mana gen yang berperan adalah CLCN2. Di sini yang mengkode protein, mengkode channel klorida. Channel klorida seperti yang kita ketahui berperan pada fase istirahat atau depolarisasi. Kemudian yang bersifat autosomal dominan, yang ini adalah bersifat sporadik, yaitu yang channel implicated in human epilepsy. Yang pertama adalah severe myoclonic epilepsy of infancy atau Dravet syndrome. Jadi ini adalah encephalopathy epileptik yang onsetnya adalah saat infant, bentuknya bisa febrile atau afebrile seizure. Kemudian bentuknya bisa bentuk myoclonic, atypical absence, dan vokal. Gen yang terkena adalah SCN1A yang mengkode sodium channel subunit. Nah, kemudian ada yang gen yang implicated in epilepsy adalah episodic ataxia tipe 1 dan tipe 2, di mana ini gen yang terkena adalah KCNA1 yang mengkode potassium channel subunit dan CACNA1A yang mengkode calcium channel subunit. Kemudian single non-ion channel gain mutation implicated in epilepsy yang kedua tadi adalah yang pertama adalah progressive myoclonic epilepsy PME. Ini merupakan kelainan yang cukup jarang pada neurologi. Jadi terdapat progresivitas deteriorasi neurologi yang progresif, biasanya ada kejang, ada myoklonus juga. Dan ini bersifat, sebagian besar bersifat autosomal resesif. Diturunkan secara autosomal resesif. Walaupun ada juga yang autosomal dominan, yaitu yang di sini disebutkan adalah DRPIA. Sedangkan yang autosomal resesif, seperti unvariculated proxy disease, kemudian cherry red spot myoclonus, lavora disease, dan Batten disease. Kemudian single non-ion channel gain mutation implicated in epilepsy yang kedua adalah autosomal dominant partial epilepsy with auditory feature, yaitu ADPEAF, yaitu merupakan familial temporal lobe epilepsy, bisa bentuknya bisa mesial, bisa lateral. Ini untuk yang lateral FTLA bermula saat childhood, kemudian saat adolescent bisa dengan keluhan halusinasi auditori, bisa tunggal gejalanya atau bisa bersama dengan gejala sensoris yang lain seperti olfactory, vertigo, dan visual symptom. Kemudian untuk yang mesial FTLA mulainya pada onset childhood, dan kemudian gejalanya khas untuk mesial temporal lobe, yaitu ada Dystrophy, kemudian ada autonomic fenomena, dan lain sebagainya. Nah, ini gen yang berperan adalah ADPEAF, di sini mengkode LGI1. Jadi LGI1 ini dieskresikan melalui presinap dan mengikat ADAM22. Nah, ketika terikat dengan ADAM22 akan menghasilkan sinyal intraselular dan menurunkan eksitabilitas. Nah, pada mutasi LGI ini akan menghasilkan kekurangan dari ADAM22 ini, sehingga akan meningkatkan dari eksitabilitas. Kemudian single gen disorder yang lain yang dapat bermanifestasi sebagai epilepsi yaitu tuberous sclerosis. Tuberous sclerosis itu merupakan penyakit epilepsi childhood yang malignan, di mana gejalanya ada West syndrome yang cukup khas, yaitu hips arrhythmia, mental retardasi, dan infantile spasm. Tuberous sclerosis ini karena ada kelainan genetik pada TSC1 dan TSC2. Kemudian kelainan yang lain yang bisa menyebabkan kejang yaitu neurofibromatosis 1, Fragile X syndrome, Rett syndrome, acute intermittent porphyria, dan leukodystrophy. Nah, yang tadi adalah single gen. Jadi single gen ini cukup jarang, tetapi kalau terkena itu diturunkannya bersifat diwariskan secara genetik dan cukup berat kalau terkena, walaupun jarang tapi cukup jarang. Sedangkan ini yang kedua adalah multifaktorial atau complex disorder. Jadi ini terjadinya mutasi dari beberapa gen dan bisa juga dipengaruhi oleh lingkungan. Jadi misalnya ada alkohol, kemudian penggunaan obat-obatan, atau misalnya infeksi pada ibu saat hamil atau pajanan zat-zatnya berbahaya, ini dapat berperan pada kelainan ini. Ini juga dapat diturunkan, tetapi agak susah diidentifikasi untuk pewarisannya. Di sini contohnya adalah myoclonic astatic epilepsy, kemudian yang cukup terkenal juga BICTS atau Neurologic epilepsy, kemudian myoclonic epilepsy of infancy, dan yang cukup banyak diketahui juga childhood absent epilepsy dan juvenile absence epilepsy. Yang myoclonic astatic epilepsy ini biasanya muncul pada usia 2 tahun sampai 5 tahun dengan bervariasi tipe kejang, dengan riwayat keluarga terdapat riwayat kejang pada keluarga dan atau riwayat kejang demam. Kemudian yang kedua adalah benign epilepsy of childhood with centrotemporal spike atau BCTS yang dikenal sebagai Neurologic epilepsy. Ini cukup sering pada anak-anak, bermula pada usia 5 tahun sampai 10 tahun dan akan sembuh sendiri, remisi sendiri. Kemudian gejalanya adalah motor orofacial atau semotor sensory seizure. Kemudian yang ketiga adalah benign myoclonic epilepsy of infancy. Ini adalah kasus yang jarang di mana mengenai anak usia 6 bulan sampai 3 tahun. Bentuk kejangnya adalah myoclonic yang singkat, kemudian dan ini mudah dikontrol dengan obat-obatan. Juga terdapat riwayat keluarga epilepsi atau febrile convulsion. Kemudian childhood absent epilepsy yang cukup sering bermula pada usia 4-10 tahun, cukup frekuent, cukup sering, frekuent untuk absensnya dan cukup berat, dan pada 44% kasus ternyata terdapat riwayat keluarga yang memiliki epilepsi. Beberapa penelitian menyatakan bahwa ini berhubungan dengan kromosom 1 atau kromosom 8. Kemudian juvenile absent epilepsy lebih dewasa, lebih tua lagi, yaitu usia awalnya adalah 10-17 tahun. Ini lebih infrequent dibandingkan childhood absent epilepsy. Kemudian ada riwayat keluarga juga, pada riwayat kejang pada keluarga. Kemudian yang membedakan, kadang juvenile absent epilepsy ini disertai general tonic-clonic seizure atau myoclonic seizure. Kemudian yang ketiga adalah gangguan pada mitokondria. Jadi gangguannya terdapat mutasi dari DNA yang bukan di inti sel tapi di mitokondria. Seperti yang kita ketahui, mitokondria adalah struktur yang berfungsi untuk menghasilkan energi pada sel. Jika terjadi mutasi pada mitokondria, maka produksi energinya akan terganggu. Nah, untuk mitochondrial disorder ini diturunkan dari ibu. Nah, contohnya adalah myoclonic epilepsy and Rett fiber atau MERRF. Itu merupakan myoclonic epilepsy yang progresif yang disebabkan oleh mutasi missense pada gen mitokondrial yang mengkode dari lisin tRNA. Kemudian chromosomal disorder, yaitu jadi ini adalah kelainan kromosom yang bisa karena ada yang hilang atau berubah, dan salah satu gejalanya adalah kejang. Contohnya adalah yang pertama adalah Down syndrome. Down syndrome itu adalah ada tambahan dari kromosom 21 yang sering kita sebut sebagai trisomi 21. Sekitar 2% sampai 15% pasien dengan Down syndrome akan mengalami epilepsi. Kemudian trisomi yang lain yang berhubungan dengan epilepsi yaitu trisomi 18 dan trisomi 13 serta trisomi 22. Kemudian sindrom yang lain yaitu Wolff-Hirschhorn syndrome, yaitu sindrom yang dimana kromosom 4-nya hilang, bagian dari kromosom 4-nya hilang, sehingga 70% pada pasien ini akan mengalami epilepsi. Kemudian ada juga Angelman syndrome, yaitu karena delesi dari kromosom 15, dan 80%-nya akan mengalami kejang pada pasien ini. Selain itu ada gejala seperti gangguan perkembangan, kemudian gangguan bicara, atau gangguan keseimbangan. Kemudian yang keempat adalah ring kromosom abnormalities, yaitu jadi ada kerusakan kromosom sehingga kromosomnya berbentuk ring shape. Ini bisa terletak pada kromosom 6, 9, 14, 15, dan 20, dan 2-3% kasusnya mengalami epilepsi. Jadi ini misalnya sebagai gambaran, misalnya pada pasien tadi infantil kurang dari 1 tahun, ada misalnya di sini ada spasm, kemudian mental retardasi, dan hips arrhythmia pada EEG. Nah, kita bisa lihat kalau misalnya tidak ada inheritance, maka kita curiga itu adalah West syndrome. Tapi kalau diturunkan secara X-linked, ini adalah curiga adalah X-linked infantil spasm. Kemudian misalnya ada pada usia anak kurang dari 1 ada prolong febrile seizure, kemudian ada prolong febrile seizure, kemudian ada kejang demam setelah usia 6 tahun, ada regresi milestone, kemudian ada febrile general seizure. Kita harus curiga itu adalah Dravet syndrome sehingga perlu diperiksa SCN1A. Begitu juga dengan kelainan yang lain. Sehingga pemeriksaan genetik ini cukup penting karena akan berpengaruh kepada konseling, kepada terapi, kepada manajemen. Jadi misalnya di sini setelah diketahui pasien dengan Dravet syndrome, kelainannya ada di SCN, setelah dicek ada mutasi pada SCN1A, maka obat-obat yang harus dihindari adalah obat-obat yang bekerja pada sodium channel blocker seperti phenytoin ataupun carbamazepine. Kemudian misalnya pada pasien epilepsi sindrom dengan GLUT1 defisiensi dengan kelainan gen SCL2A1 itu treatment yang disarankan adalah ketogenic diet. Begitu juga hal ini juga berpengaruh juga kepada edukasi ke pasien, misalnya pada pasien misalnya dengan juvenile myoclonic epilepsy yang kita ketahui ada kelainan di Gabra 1. Nah, kita akan edukasi pasien ini akan tidak akan bisa sembuh, artinya kejangnya akan muncul terus, akan tetapi bisa dikontrol dengan obat. Hal ini akan berpengaruh pada konseling ke pasien sehingga pasien siap kalau minum obat dalam seumur hidup seperti itu. Atau misalnya pada Neurologic Epilepsy atau BECTS, kita edukasi setelah diketahui BECTS, kita akan edukasi pasien bahwa BECTS ini akan sembuh sempurna, remisi sempurna setelah usia di atas 13 tahun, sehingga pasien akan berpengaruh ke prognosis dan ke edukasi kepada pasien. Jadi genetik literasi ini adalah penting untuk kita sebagai neurologis ataupun epileptologis, dan ini membutuhkan data yang cukup, pedigree yang cukup paling tidak sampai 3 generasi. Kemudian molecular diagnosis ini penting juga untuk pasien dan keluarganya dalam hal mempersiapkan prognosis, mengedukasi, kemudian juga dalam hal manajemen seperti tadi obat-obat yang dihindari dan direkomendasikan. Dan terutama ini sangat penting untuk pasien anak. Terima kasih, saya kembalikan kembali kepada Dr. Eri sebagai moderator.
Ya, terima kasih banyak Dr. Atitya. Thank you very much Dr. Atitya for the presentation. It's very interesting. Saya juga jadi belajar banyak ya tentang epilepsi karena ternyata begitu banyak gen yang terlibat dan terjadi di berbagai sindrom gitu ya. Jadi sangat menarik. Ini juga mungkin akan menambah pengetahuan kita tentang epilepsi di sisi genetika karena juga untuk memanage pasien dari hasil genetiknya. I will go to the third speaker. It's Dr. Rusdy Ghazali Malueka. He's a lecturer and researcher in Department of Neurology, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. He's currently a vice chairman of Neuro-Oncology Tumor Board in Sardjito Hospital and also head of stem cell team in Faculty of Medicine, Universitas Gadjah Mada. He completed his medical doctor in 2007, received his specialist in 2017, and Ph.D. in 2012. And he's a consultant of neuro-oncology in 2021. Okay, he also has many publications in national and international journal. So, Dr. Rusdy, you will have 30 minutes for the presentations of genetic in brain tumors.
Thank you very much, Dr. Eri. Can you hear my voice?
Yes, it's clear.
Can you see my slide?
Yes.
Okay, so please inform me if there is anything wrong. I'm not really confident with the signal. I hope it will be okay.
Yeah, okay.
So thank you very much for the opportunity, Dr. Eri. And first of all, I would like to say hi and thank you very much for Professor Masafumi Matsuo for being able to join in our lecture this morning. I think some of the students, most of the participants here are our students in neurology and pathology department. So some of you probably already met him before. Around 2 years ago, he visited our department for also guest lecture and also discussing about research and collaboration like that. And because of the pandemic, it has been, I think, more than 2 years that we don't invite him to our department. So yeah, we try now using this online forum, but of course we hope next time we can visit Japan again, or Matsuo Sensei can visit Indonesia again, and we can have a more fruitful discussion that way. All right, so I have my duty today is to present about genetics of brain tumor. So I will try to focus on clinical applications. It will be impossible to explain everything in 30 minutes, so I will try to make it short. And I will try to focus on some diseases that, some gene that probably will be very relevant to clinical practice and our daily practice, especially as a neurologist, as most of us are here, and also as pathologists, as some of us are here. So I will start with a case. So this case is our own case in Sardjito Hospital. So a male, 64-year-old, come with a complaint of headache and weakness of the left limb. So the history shows that since 3 months before admission, the patient's complained of headache accompanied by nausea, vomiting, and blurred vision, which was then followed by weakness of the left limb. Physical examination shows a cranial nerve 7 and 12 palsy, also with slight hemiparesis on the left limb, upper and lower left limb. And other than that, it's quite normal actually for the patients. We did MRI and shows that it seems like there is a high-grade astrocytoma, a type of high-grade brain tumor in the patients. So the next question is, what is the diagnosis of the patients? And what is the treatment? Should we do surgery? Should we perform radiotherapy for the patients? Should we give chemotherapy? And basically, what is the role of genetics in all that? Why do I show the case? Is there anything related to genetics? And that's what we will see in the next slide. So let's speak a little bit about genetics of brain tumors. So primary brain tumors is a diverse group of neoplasm arising from different cells of the central nervous systems. This is actually quite rare, but the mortality is very high. So there is a disproportionate proportion between the case number and the amount of death contributing to the total death caused by cancer. So in adults in the United States, around 23.8 cases per 100,000 persons, while in children is 6.1 per 100,000 children. And we can classify based on the histopathology examination into 2 big classifications, the glial tumor or glioma and non-glial tumor or non-glioma. For non-glioma, we recognize meningioma, schwannoma, lymphoma, craniopharyngioma, and so on. For the glioma, we can see the astrocytic type or astrocytoma. We can see also there are ependymoma from the ependymal cells.
I found this on the web.
We found also medulloblastoma, mixed glioma, anaplastic ganglioglioma, and so on. And the most common one, according to the data from the United States from 2008 to 2012, is around 36% for meningioma, followed by around 23% for glioma. In Indonesia, I think we have, it depends on the center, but in some centers, the glioma is more than meningioma, but always these 2 are the biggest one. So today I will try to discuss genetics of these 2 topics only because we don't have time to discuss all. So we'll discuss about genetics of glioma and genetics of meningioma and how is the role in the treatment of our patients. So let's start about glioma. As you already know, glioma refers to tumors that have histologic features similar to normal glial cells. So they are divided into astrocytoma, oligodendroglioma, and ependymoma based on the cells type that we found in histopathology examination. This is one of the most common primary CNS tumors in adults. And the new classification is actually 2021 WHO classifications. And it's important to know that since 2016, the WHO already classified CNS tumor based on molecular parameters. So this is opening the door of personalized medicine in the term of neuro-oncology. And in 2021, they go even deeper, they go even further. So the current classification, the 2021 WHO classification is actually advancing the role of molecular genetics in CNS tumor classification. We see the data from our hospital, from Yogyakarta. We see that among the glioma, the most common one is astrocytoma, 82% in Yogyakarta, followed by ependymoma and so on. From the astrocytoma, we see that 43% are high grade, so grade 4 astrocytoma or glioblastoma, followed by grade 2, the diffuse astrocytoma, and grade 3. And then the last plus is grade 1. And speaking about genetic of glioma, we can see everything summarized in this picture. So this is a very complicated picture. I will not use this picture, but this is good picture to show the mutations involved in glioma formations and the target of that mutation, what is actually happening in the cells. You can see Krebs cycles are involved through IDH mutation. The cell cycles are involved to a lot of other mutations in this area that I will explain one by one. So this is the legendary picture from Lu et al. In 2019, a very good picture summarizing the mutations happen or the genetic alterations happen in patients with glioma. divide it into primary and secondary glioblastoma, we can see that the first one, the first driving mutations that happen before everything else is IDH mutation. So this IDH mutation is the driving mutation. This is the mutation that appear very early, and these mutations will result in other mutations. So this is a driving mutation that will drive other mutations to happen in the patient. So if the patients have IDH mutation, the other mutations will also happen. If the mutations happen in P53 gene or at the TRX gene or PDGFA gene, then they will become diffuse astrocytoma. If these mutations is followed by 1p19q deletion, then that will be oligodendroglioma. So these mutations, the IDH mutations, will drive other mutations. Then depend of that mutations, the histopathology type will be determined. If it is P53 mutations, it will be diffuse astrocytoma. If it is 1p19q deletion, it will be oligodendroglioma. And after that, other mutations will also accumulate. And by the loss of 10q and 19q chromosome, the patients will have the highest grade of tumor, which is secondary GBM grade 4. In the other hand, in the wild type patients, these things can happen: EGFR amplifications, and then MET2 amplification, CDK4 amplification, and so on, which will then result in GBM without undergoing this lower grade tumor. This is what we call as primary glioblastoma or primary GBM. These tables, these pictures come out very often in the neurology national examination, so it's a good idea to remember this picture. So this is top 20 gene mutated in GBM. We can see that the most common one is actually TP53 mutations. That's like in the other type of tumor. And the IDH1, ATRX, and so on is actually not as high as P53, EGFR, and P10 and the other type of gene. But this is the most significant one in terms of prognosis, in terms of diagnosis, and in terms of targeted therapy. So this is these are the 20 genes commonly mutated in patients with glioblastoma. Again, as I mentioned before, IDH1 mutation is an early event in the development of astrocytomas and oligodendroglioma. So these are the most significant mutations in brain tumor, in this case, glioma. So what is IDH gene? So IDH genes encode 3 types of protein, 3 types of enzyme, which is IDH1, 2, and 3. So this enzyme is very important in cell defense against oxidative stress. Why? Because they will convert isocitrate to alpha-ketoglutarate or alpha-KG. And most common mutations happen in the codon 132 of this gene. It's C395G2A mutations with the amino acid chains R1322H. 90% of patients have these mutations. While the rest, there are other mutations to fill up the rest, but the most common one after this mutation is at codon in IDH2 gene in codon 172. So C515G2A R172K in the amino acid level. So this is the mutations. This is the most common one, 90% IDH1 R132H. The other 10% are divided into this IDH1 and IDH2 mutations, R132L, GS, and R72K for IDH2, and so on. So the change is only in one nucleotide, CAT in this mutation, and then TGT, the T in this mutation, and so on. So the CGT is the wild type one. This is the more detailed explanation about the glioma formation and role of IDH in that formation. As we can see here, this left side, the A column here is for the normal one, the wild type patients, while the right one here for the IDH mutations. I will not explain this in detail. I just need to show you that when the mutations happen, then several things will happen. In the end, what will result is that there will be DNA hypermethylation. So the hypermethylated DNA. We know this is a very important epigenetic mutation mechanism to actually increase or decrease expression of several genes. So the DNA hypermethylation will happen if there is mutation in this IGH. The next one also, there will be an increase or hypoxia inducible factor 1 alpha. So this is caused by this dehydroxyketoglutarate, which will then increase the formation of this hypoxia inducible factor, which will then result in the increase of VEGF. So then the VEGF, as we know, will increase the formation of new blood vessels or angiogenesis. So this is the mechanism of IDH mutation in causing glioma. And how is actually the role of this in treatment? How is the role of these mutations in patient prognosis and management? So many research have consistently showed that gliomas with IDH mutations will have a better prognosis. This picture clearly shows that, and our own study in Yogyakarta also clearly shows that. And this is a summary of that study. So in patients with GBM IDH wild type who receive treatment, complete treatment, surgery, concurrent chemoradiotherapy, and then chemotherapy adjuvant with alkylating agent, we will expect the life expectancy to be around 15 months for the wild type, while for the GBM IDH mutant, it will be around 31 months. So there will be double the increase of lifespan in patients with IDH1 mutation. And patients with IDH mutation will also have better response to other chemotherapy, not just temozolomide, but also for PCV, lomustine, vincristine, and so on. This is the result in Yogyakarta that we published last year, showing that yes, in our population also, the patients with IDH mutant will have significantly increased survival compared to patients without IDH mutations. So as we can see here, 42.4 months for IDH1 mutant patients, and only 10.5 months for patients without IDH mutations. So very significant difference in overall survival between these two groups. And we can also see here in the Yogyakarta that most of the patients, almost 80%, are actually do not have these mutations. So only 21% will have these mutations in our population, which is quite similar to some study in Malaysia and Thailand, but actually quite lower compared to study in other Western countries. All right, so we know that IDH have a role in prognosis and diagnosis of glioma, but can we actually try to target this mutation? Can we actually target these mutations to be able to reverse the things that happen in the patient so that the patients can have better prognosis or better outcome after the treatment? So can we do targeted therapy to IDH1 mutation? The answer is that until now, not yet. So we have had several publications, several studies who try to study some agents that will target this mutation. I mentioned some of them here, and one of them, which is very famous, is the valproic acid, because this is inhibitor, HDAC inhibitor. We know it will also help in reversing the kind of changes happen because of this mutation of the IDH gene. But unfortunately, it doesn't show significant correlation with patient survival. There is one publication from Weller et al. In the early 2010s showing that valproic acid will increase survival, but bigger data, larger study using larger samples shows that it is not so. Other things like perampanel is actually now also proposed for this purpose, but we have not yet had any data on that. There is no yet human trial for that. The next mutation, which is also very important, is 1p19q codeletion. This is a deletion, so deletion of this arm, 1p arm and 1q arm of this chromosome. So the long arm of the chromosome 19 and the short arm of chromosome 1. If the patients have these mutations, then the patients have oligodendroglioma. So this is very significant and very important marker for diagnosis of oligodendroglioma. These mutations meaning the diagnosis is oligodendroglioma. So that's very important. What if the examination shows that the pathology doesn't fit with this diagnosis? Then we will still go with the mutation. The oligodendroglial tumor is with 1p19q codeletion. So molecular marker trump pathology diagnosis. All right, so the mechanism is not yet clear because what are the genes deleted in this process of codeletion is not actually clear right now. And this is a very important predictive markers. It's a strong predictors of chemosensitivity and radiotherapy sensitivity. So as we can see here, if the patient is oligodendroglioma wild type, the survival is around 2.7 years. But if there is deletion in these two chromosomes, the survival is around 7 years. So very, very significant difference. And also the patients will respond better to alkylating chemotherapy using PCV and also to radiotherapy. With if we give PCV to the patient, the survival will reach almost 15 years. While in the patient with wild type, without this deletion, the outcome after giving PCV will not be different with outcome with radiotherapy only. So this is very significant difference. All right, based on that, WHO then classified the mutations, classified the glioma based on the mutations found. So I will not explain this in detail, but the point is that if there is no more what we call oligoastrocytoma or mixed glioma. So we diagnose this type of condition using genetic diagnosis. If there is one P19Q co-deletion, then the patients will be oligodendroglioma. If there is no one P19Q co-deletion, then the patients will be diffuse astrocytoma. So there is no more anaplastic oligoastrocytoma. There is no more oligoastrocytoma. All right, so this is a very important difference from previous classification in 2007, which still have oligoastrocytoma as one of the tumor types in glioma, but now they don't have that type anymore. And this is the results from several studies which shows the role of these mutations in patients' prognosis. And we can see a very significant difference among the patients with and without mutation. IDH without mutation, 3 years. IDH with mutation, 7 years, according to NOA4 trials in grade 3 glioma. In other study, in TOG 9804, wild type IDH 3 years, IDH mutant 8 years, and so on. So this clearly shows the mutation have a preferable prognosis. And we can see here, astrocytoma without IDH mutation, the overall survival is only 1 to 5 years. For example, grade 2, grade 3, we can expect around 5 years, maybe the maximum for the patients. But with mutation, we can have much longer than that, 7, 8 years, or even a decade of the patients in stable condition. While in oligodendroglioma with mutations, the survival could exceed 14 years, like I mentioned before, 15 years in several studies. So based on that, then WHO reclassified this mutation, this tumor based on the type of mutations happen. For example, astrocytoma diffuse IDH mutant, glioblastoma IDH mutant, and IDH wild type. So the diagnosis already include molecular characteristic. However, that improved even more in 2021 WHO classification of the tumor of the central nervous system. What is important in this new classification is that if there is no more glioblastoma IDH wild type, so glioblastoma, there is no more glioblastoma IDH mutant. So glioblastoma grade 4 will be IDH wild type. For IDH mutant, if it is grade 4, we call them IDH mutant grade 4 astrocytoma. So we don't call them glioblastoma anymore because glioblastoma will not have IDH mutation. So I think that's the most important difference from 2016 WHO classification. All right, the next mutation, which is also important but rarely studied in Indonesia, is epidermal growth factor receptors. I will not explain in detail about this. The point is that there will be deletion of exon 2 to 7 of the EGFR gene, which will result in frame deletion of 267 amino acids, so that this protein cannot attach to the ligand, and this will cause the signs and symptoms that the patients have. The good thing is that there are a lot of agents that can inhibit this mutation. As we know, there is an agent called tyrosine kinase inhibitor, or TKI, widely used in patients with non-small cell lung cancer with mutation in the EGFR gene. For example, deletion of exon 19 of EGFR gene, we will give this TKI. However, study in human until now didn't show significant results. So all are negative study. Why? Because maybe there is other resistance mutations, maybe because the medicine cannot cross blood-brain barrier effectively, or maybe because there are other factors affecting it. The other one is VEGF expression. We know this is the gene that will result in the endothelial cell growth and angiogenesis. This has been reported, VEGF increased expression in glioma. The higher the grade, the more the VEGF expression. So this is one of the therapeutic target using medicine called bevacizumab, that is VEGF inhibitor to patients with high-grade glioma. And it's already being approved in the United States for the patients with recurrent glioblastoma, because the result with combination with irinotecan shows that it has better progression-free survival and overall survivals compared to patients without bevacizumab. However, this is not approved in Europe, because if you see the Kaplan-Meier curve, actually there is not really, the difference is very minimal between these two groups. So Europe doesn't approve it, but FDA approved this medicine for recurrent glioblastoma. The next one, which is also very important, I still have maybe 5 minutes to explain about this. So MGMT methylation status. As you probably already know, 0,6-methylguanine is one of the major mutagenic lesion in DNA. So if this happens, then this will pair with thymine during DNA replication, which will result in cell death. So our body has a natural mechanism to deal with this mutation, which is called MGMT, 6-methylguanine DNA methyltransferase, which is an enzyme that will remove the alkyl groups from this O6MG that then will result in the cell survival. The cells will not be dead because of this. The problem is that this protection mechanism will also protect the cells from chemotherapy agent, especially the alkylating agents temozolomide. That's why if the expression of MGMT is lower, the patients will be more chemosensitive. So one of the mechanisms to lower expression of MGMT is called MGMT methylation, or CpG methylation in the promoter region of the MGMT gene, which will result in lower MGMT gene expression, which will result in lower MGMT enzyme secretion, which will result in more response to chemotherapy using temozolomide. So the simpler picture will be like this. If MGMT gene active because of unmethylated MGMT promoter, the patients will be chemoresistant. If the MGMT gene is inactive because of the methylation of the MGMT promoter, the patients will be chemosensitive. So this is a very important prognostic factor, a predictive factor in treatment of temozolomide in glioma, which is why this is mentioned as the most powerful molecular prognosticator in malignant gliomas and already included in the standard treatment. And this is proven with a very important study by Perry et al., which shows that in patients with MGMT methylation, it is more sensitive to chemotherapy compared to patients without MGMT methylation. So this is a very landmark study which shows the role of MGMT methylation in patients with glioma undergoing chemotherapy. Unfortunately, the distribution of MGMT promoter methylation is different based on the tumor types. So the most one is anaplastic oligoastrocytoma is around 80%. Anaplastic oligodendroglioma is around 80%. While in GBM itself, it's only around 50% will have this MGMT methylation. So the number varied widely depends on the type of the tumor. And this table summarizes the difference in between MGMT methylated and unmethylated with chemotherapy. Without chemotherapy, we predict 13 months. With this, without methylation, we predict 13 months if the patients have chemotherapy and radiotherapy. But with methylation, we have 22 months for this temozolomide chemotherapy. We studied in Indonesia, but the sample is still too low, I think, right now, so we don't have any definite conclusion about this. So in conclusion, the glioma markers which are important are IDH1 and 2 mutations, 1p19 key codylation, MGMT promoter methylation, EGFR mutation, and VEGF increased expression. Each have its own function. Some are diagnostic markers, some are prognostic factor, and some are predictive factors. So this is summarized in this table. For example, IDH mutation is a diagnostic factor. Also, it is a prognostic marker because patients will have much better survival. It's also a predictive factor because patients will respond better to temozolomide. It's also targeted therapy because the patients can probably be treated with several agents which targeted this mutation, but the result now is not conclusive yet. So this is the summary of this molecular markers in glioma. I will see a little bit about meningioma. The point is that what we know so far, meningioma is classified based on this criteria: mitotic rate, brain invasion, and so on. So this is the diagnosis that's commonly used to divide meningioma to grade 1, grade 2, and grade 3. And several studies already shows type of mutations in meningioma. And the most famous one probably is NF2 mutation that we see happen in almost all types of meningioma and with very high percentage too. So this is a very important type of mutations. And different location of the meningioma will show different prevalence of mutation. So for example, in the infratentorial tumor, these mutations are more common, P13KCA and so on. And in the convexity meningioma is NF2. In Fox meningioma, NF2, TRAF7, and P3. So different location will have different type of mutation. And so these are the medicines which are currently being studied in the treatment of meningioma. AKT1 inhibitor, Hedgehog inhibitor, SMO mutations, NF2, FK inhibitor, immune checkpoint inhibitor, and so on. But so far, the results are still negative. So we don't have yet medicine for this meningioma mutation. All right, so how is the clinical application? The recommendation in our guideline is clear. If you have the facility, you need to check these three things: IDH mutation, MGMT methylation, and 1p19q coagulation, if you have the facility. The level of evidence is 1B, and level of recommendation is A, so very high level of recommendation. The other things you don't need, ATRX and everything. If you have, that's good. If you don't, then it's okay, because these three are the main one. And what did the guidelines say? Our guideline PNPK tumor otak 2019 and NCCN guideline and EANO guideline. You see in the EANO guideline, it's clearly incorporate mutation, MGMT methylation in this case, ADH mutation and so on, in determining the therapy for patients with glioma. And this is NCCN guideline also clearly in high-grade glioma. We define the treatment based on the methylation status of MGMT promoter. In low-grade glioma also, we define the treatment based on low risk and high risk based on the presence of sequence-verified IDH mutation. And also in our national guideline, we also incorporate this genetic factor. We mentioned that the patients with methylated and unmethylated MGMT promoter will have different type of treatment and so on. So it's already incorporated in our guideline. So how can we use that knowledge in our patients? So this is the case that we discussed in the beginning. The patients who have headache and left extremities weakness, and the MRI shows high-grade astrocytoma. How is the diagnosis, treatment, and how is the role of genetics in that? So based on our guideline that we mentioned before, we need to discuss in a multidisciplinary team, and after that, we perform maximal self-resection. So the neurosurgeon in our team perform the resections, and then the pathologists see that this is a grade 4 glioblastoma. And then our group do the mutation analysis using Sanger sequencing, shows IDH wild type. And then we also perform quantitative methylation specific PCR. I need to mention that the guideline and EANO clearly mention that the only accepted way of diagnosing methylation in this case of the MGMT is only methylation specific PCR. But I know in a Mani center in Indonesia, we can only do IHK, immunohistochemistry. That's okay, but if you can do methylation specific PCR, that will be the gold standard. So the RT-PCR clearly shows that this is unmethylated MGMT. So based on that, the diagnosis of patients is glioblastoma, IDH wild type grade 4, so according to WHO classification. And let's see the EANO guideline. EANO guideline in patient with IDH wild type, WHO grade 4, with age less than 70 years is concurrent chemoradiotherapy with temozolomide and adjuvant with temozolomide. Let's see in the NCCN guideline, same thing. The patients less than 70 years old with unmethylated MGMT, standard brain radiation therapy with concurrent temozolomide and adjuvant temozolomide. In our own national guideline, same things, unmethylated, we do radiotherapy with temozolomide. So the same conclusion we have from 3 different guidelines, European, United States, and our national guideline. So that's what we give to the patients. We give temozolomide to the patients, and then we give radiotherapy concurrent with temozolomide, and after that we do adjuvant treatment for the patients. How is the prognosis? So this mutation can also be used to predict prognosis of patients. So overall survival of glioblastoma without IDH mutation, like I mentioned, is 27 months. With mutation is 14 months. With mutation is around 30 months. Now, the overall survival of GBM without MGMT methylation with chemoradiotherapy is around 13 months. I mentioned about this before. So in these patients, we predict the survival around 13 to 14 months, which is actually quite accurate because the patients pass away after 13 months and 10 days. So it shows the importance of molecular markers of genetics in prognostication of the patient and determining the prognosis for the patients. So in conclusion, the 2021, and 2016 WHO classification already integrates genetics characteristic with histopathological types of central nervous system tumors. And this is improved more in 2021 guideline and already incorporated in our own national guideline. So the management of brain tumors need to include the genetics characteristic. And we in our group in the molecular biology laboratory already routinely do this examination. So if you want to do this test, you can actually send the samples to us. We'll proceed with the work, and then we'll inform you the results so that it probably will affect the treatment and prognosis of your patients. Thank you very much.
Okay, thank you very much, Dr. Rusdy, for very comprehensive presentations regarding genetic in brain tumors. We will go to the next session, it's discussion sessions. We have already some questions from Professor Matsuo and also for Dr. Atitya. I think for Dr. Rusdy, if you have any questions for him regarding genetic and brain tumors, you can also put your questions in chat box in this Zoom meeting. And I also remind you to fill the attendance form, because you will receive e-certificate from joining these international guest lectures. Okay, so we will go to the discussion sections for Professor Masafumi Matsuo. Sensei, you have some questions. First is from Dr. Dewa. He asked about the a part of the classically well-identified chromosomal changes. Are there any clinically significant non-coding region alteration in Duchenne muscular dystrophy? And the second question is the clinical practice. We have encountered several clinically suggestive DMD cases from remote area in our country. How do we enroll those patients so that they may get access to novel DMD trial or therapy? Professor Masafumi Matsuo, perhaps you can turn on your video and answer the questions.
Yes. Thank you for the question. For the question one, the question is non-coding region has a meaning in that. Sorry.
Yes.
This is very important. Even though a non-coding region, it has a function in the gene, because sometimes a single nuclear change in the intron create a pseudo exon that is incorporated to the mRNA. So it's called a DMD. So therefore, many doctors have problem in the diagnosis of DMD by using MLPA, because MLPA only focus on exons, but sometimes the intron mutation causes DMD. In that case, it's very difficult to analyze the whole region of intron because it's so long. So we usually use mRNA analysis to identify intron mutation. In that case, pseudo exon is incorporated into mRNA. So the conclusion is that nuclear change in intron has sometimes a meaning in DMD. This is the answer to question one.
Yes, thank you, Sensei.
The second one is DMD therapy.
Yes.
I don't know Indonesia situation, but in Japan, so it's recognized as a drug covered by health insurance system. So patient doesn't need to pay for that. But in Indonesia, what happened? I don't know.
It's not covered by insurance, Prof. It's not covered by insurance, Sensei.
Oh.
And in Indonesia, we need to identify the mutation first. So that's the first one is already difficult.
Yes.
Please discuss about this in the officials.
Okay. Okay, Sensei. I hope Dr. Dewa, you satisfied with the answer from Matsuo. So for the intronic mutations, we can analyze from the mRNA in mRNA level because it's easier to identify than if we analyze the whole intron because it's very large. And for the cases in Indonesia, it's still being developed because for the DMD therapy, it's genetic based, so we need to have the data first for the genetic, and we still struggle to collect the data. And then you have second questions, Sensei, from Dr. Ari from Ekman's Institute. The first question is, how long does the effect of the exon skipping last, and whether this therapy must be done for the lifetime of the patients, and has there been any side effect reported for by this therapy, Sensei?
So for the first question, it lasts at least 1 week, and so every week a patient receives the ASO treatment. But in the future, maybe once a month treatment is enough, but it's needed time to decide it. Currently, once a week treatment was being done in the patient. But so every week, the patient must receive the treatment for his life.
So it's a lifetime treatment then, Prof.
And the second question, no, there are no side effects specific to exon skipping.
There is no, Sensei.
No risk.
Yeah. Yeah, thank you, Sensei. I hope Dr. Ari, you satisfied with the answer from Prof. Matsuo. Then if it's a lifetime therapy, then it will be very expensive, Sensei.
Yes. So even in Japan, that must be covered with healthy insurance. Otherwise, anybody can support that. That's why he's married.
Yes. Yeah. So it's also one problem in our country then. Okay, Sensei, for the third questions is come from Dr. Saras from anatomical pathology residence. The question is why CK levels decrease with the increase of the age. Meanwhile, the DMD symptoms get worsened with the age.
Oh, good question.
Thank you, Sensei. It's my residence.
Because CK is released from muscle. So in the aged patient, muscle wasting is very severe. The volume of muscle is small. Then the level of CK becomes low. So the level of CK correlates with the amount of muscle. Therefore, in the aged patient, CK level decrease.
Yeah.
That's the question answer.
Yeah.
Thank you, Sensei. I hope Dr. Saras will, and because his thesis is about DMD, Sensei. Okay, for the next questions, perhaps a committee can share a question for Dr. Atitya. Okay, Dr. Atitya, there are several questions for you. Can slide show again? Yeah. This is come from the residents, Dr. Sonia. Is it necessary to screen the epilepsy genetically in children, and is it can be prevent? Mungkin bisa dijawab di bahasa Indonesia, tidak apa-apa, Dr. Tia. Saya cuma biar Prof mungkin mengerti pertanyaannya. And for therapy, patients with genetic epilepsy, how is the treatment? Is it a lifetime treatment also? And the third one is epilepsy cases often occur with Down syndromes, and does it need special therapy? Yes. Okay. Thank you, Dr. Sonia. Dr. Atitya, you can answer the questions.
Okay, thank you, Dr. Eri. I will answer in bahasa ya, Dr. Eri.
Ya, terima kasih, Dr. Tia.
Jadi apakah perlu dilakukan screening untuk pada anak untuk epilepsi genetik ya? Memang kalau memang genetik ini sebenarnya kalau mau dirutinkan akan jadi mahal sekali karena pemeriksaannya cukup mahal ya, dan ada banyak gen yang diperiksa. Jadi biasanya pasien itu ketemu ya bukan sebagai screening, jadi sebagai karena sudah diketahui misalnya ada kejang bentuknya misalnya sindrom tertentu dengan kecurigaan gen tertentu sehingga dilakukan pemeriksaan gen tersebut. Nah, itu baru biasanya baru diketahui, dan kalau memang ada mencukupi biaya bisa dilakukan dengan kepada keluarganya. Keluarga akan tapi cukup banyak ya, akan cukup banyak yang dihabiskan untuk biayanya. Sementara untuk treatmentnya juga ada yang bisa dikendalikan, ada bisa dikendalikan dengan obat anti epilepsi, ada yang tidak. Nah itu sebenarnya bisa kalau misalnya mau dilakukan screening, tapi itu membutuhkan biaya yang besar, terutama yang autosomal dominan itu sebenarnya bisa, lebih baik bila dilakukan screening. Tetapi ya tadi mungkin belum memungkinkan di sini. Kemudian yang kedua, untuk terapi pada pasien dengan epilepsi genetik, apakah pengobatan perlu dilakukan seumur hidup? Jadi tadi ada beberapa macam ya kelainan genetik, jadi misalnya seperti single gen atau polygenik dan lain sebagainya. Nah, itu tergantung dari tipe-tipe apa atau sindromnya. Jadi kalau misalnya seperti juvenile myoclonic epilepsy seperti itu terapinya memang seumur hidup. Atau misalnya seperti yang tadi ada tuberous sclerosis dengan West syndrome seperti itu, terapinya juga biasanya lama, dan untuk West syndrome kadang sering resisten. Kemudian tetapi seperti misalnya kelainan seperti Sp.S, GS, general epilepsy, febrile seizure itu, febrile seizure plus itu dapat sembuh sendiri. Jadi memang tergantung dari sindromnya. Jadi memang PR kita adalah mencari sindrom epilepsinya, terutama pada anak itu cukup banyak sindrom epilepsinya, berbagai macam. Jadi ditegakkan dari anamnesis, dari onsetnya mulai kapan, bentuk kejangnya seperti apa, kemudian EEG-nya seperti apa, kemudian imaging-nya dan komorbidnya itu baru kita bisa mendiagnosis itu sindrom apa. Kemudian setelah itu dicek genetiknya kalau ada kelainan genetik. Jadi ini tergantung dari jenis sindromnya. Jadi ada yang bisa sembuh sempurna, ada yang memang bisa harus minum obat seumur hidup tapi terkontrol, ada yang memang sulit dikontrol, itu berbeda-beda. Kemudian yang ketiga, pada kasus epilepsi yang cukup sering pada Down syndrome, apakah ada terapi OI khusus? Jadi untuk Down syndrome kelainannya adalah pada kromosom. Ini berbeda seperti dengan Dravet syndrome. Dravet syndrome itu kelainannya pada SCN1A, sehingga ada terapi khusus, misalnya tidak boleh diberikan obat-obat yang bekerja pada channel natrium seperti misalnya carbamazepin ataupun phenytoin. Tapi kalau Down syndrome ini karena kelainannya pada kromosom, tidak ada obat anti epilepsi khusus, hanya saja nanti menyesuaikan dengan tipe kejangnya. Kemudian ada komorbid apa pada pasien tersebut, misalnya ada gangguan kognitif pada pasien tersebut, maka kita berikan obat yang tidak menurunkan kognitifnya, atau justru yang memperbaiki kognitifnya seperti itu. Mungkin itu Dr. Eri.
Ya, terima kasih Dokter Atitya. Semoga menjawab pertanyaan ya Dokter Sonia. Nanti mungkin jika masih ada yang ingin ditanyakan, nanti mungkin bisa bertemu langsung dengan Dokter Tia ya.
Tiap hari ketemu Dokter Sonia.
Tiap hari ketemu Sonia, Dokter Sonia aja. Kemudian dari Dokter Ari Setiagraha dari Ekman Institute juga menanyakan, jika kejang pada anak usia kurang dari 1 tahun, apakah harus ada follow up atau apa yang harus diperhatikan untuk mengantisipasi supaya tidak terjadi lagi begitu, Dokter Tia?
Baik, terima kasih Dr. Ari Satyagraha. Jadi memang untuk anak-anak banyak yang menyerupai kejang. Jadi lebih susah memang mengidentifikasi kejang pada anak, apalagi pada usia kurang dari 1 tahunnya. Jadi kita kalau ada kejang, kita pastikan dulu apakah ini memang kejang atau bukan. Karena apalagi untuk anak-anak banyak yang menyerupai kejang. Nah, kemudian kalau ada kejang, kalau itu yakin itu adalah kejang, kita pastikan ini kejangnya apakah ini epilepsi atau bukan, non epilepsi. Nah, kejang yang disebut untuk definisi kejang epilepsi adalah kejang minimal, kejang yang unprovoked. Unprovoked itu artinya bukan karena kelainan strukturalnya akut, atau bukan karena misalnya karena pada anak-anak misalnya gangguan elektrolit yang cukup sering, misalnya pada hiponatrium, hipokalemi ataupun hipoglikemi. Itu harus dipastikan dulu itu bukan. Nah, kejangnya harus unprovoked dan minimal adalah 2 kali. Dengan jarak antara 2 kejang adalah lebih dari 24 jam. Itu baru bisa kita definisikan sebagai epilepsi. Nah, kalau masih satu kali, biasanya kita observasi dulu. Kita observasi. Kalau semoga tidak ada kejang lagi. Kalau misalnya ada kejang lagi dan kejangnya itu unprovoked, artinya bukan misalnya dia habis diare muntah-muntah seperti itu, kemungkinan kan ada gangguan elektrolit, kita cek elektrolitnya no abnormal, berarti itu provoked masuknya. Jadi kita yakin itu unprovoked, baru kita lakukan misalnya elektroencephalografi sambil dicocokkan apakah ada ke arah sindrom tertentu. Jadi untuk Dr. Ari, jadi kita pastikan dulu itu kejang atau bukan. Kejangnya itu karena ada penyebab tadi seperti gangguan otak akut atau gangguan metabolik atau bukan. Kalau iya berarti bukan epilepsi, tapi kalau bukan kejang bukan kejang yang unprovoked, sehingga itu tidak dicurigai sebagai epilepsi. Nah, untuk antisipasinya mungkin karena ini belum tentu ini kejang epilepsi, jadi hal-hal yang dapat mencetuskan kejang, misalnya tadi hipoglikemi, lapar, atau misalnya gangguan elektrolit, itu bisa dihindari. Ataupun sebenarnya kalau kejang epilepsi pencetusnya adalah kurang tidur, kemudian kelelahan, cahaya yang berlebih, bisa dari sinar matahari atau bisa dari TV ataupun HP, atau kelelahan atau pikiran, itu bisa mencetuskan kejang. Itu yang mungkin yang harus diperhatikan. Terima kasih mungkin Dr. Eri.
Terima kasih Dr. Atitya. Mungkin masih ada pertanyaan untuk Dr. Atitya? Atau kita ke Dr. Rusdy dulu ya, mungkin sudah ada pertanyaan untuk Dr. Rusdy. Ya, ini ada pertanyaan. Is there any possibility to examine the mutation of IDH and MGMT mutation in blood samples? We know some patients tend to avoid brain surgery while there was necessity to treat the tumor. And then the second question is in limited source health center, is there any difference of tumor morphology in imaging or clinical symptom of IDH mutant compared to wild type? And the third one, is there any role of microRNA on glioma diagnosis and treatment? Dr. Rusdy, perhaps you can answer the questions.
Okay, thank you very much, Dr. Eri. So the IDH mutation is somatic mosaicism mutation. So it will not be able to be detected in the peripheral blood. We need the tissue samples of the tumor. So that's the one weakness of IDH mutation analysis. But MGMT methylation, yes, you can detect MGMT methylation in peripheral blood in leukocyte, for example. However, the correlation with the brain MGMT methylation level is poor, maybe. I mean, the study which is already done correlating the MGMT methylation in peripheral blood leukocytes with the tumor samples is in colorectal cancer. In colorectal cancer, it's clear that there is poor association between peripheral blood leukocyte MGMT methylation with the tumor tissue MGMT methylation. We don't know yet how is it in the brain, but I assume if it will be around the same, so that the possibility to actually replace the MGMT methylation analysis from the tissue samples with peripheral blood one at this moment, I think, is quite slim. So I think, yeah, we still need the tissue for that. On the other hand, the tissue also, we need that for diagnosis of the histopathological level. So we still need the biopsy of the brain or the tumor sample of the brain. The molecular marker, especially from the periphery, until now is not yet able to replace the histopathology examinations in terms of histology diagnosis. For the second question, this is a very important topic. We call it radiogenomics. So this is has been extensively studied and undergoing several important studies also. There are some characteristics of IDH mutation which will be represented in the MRI lesson. For example, more peritumoral edema, larger tumor size, more central necrosis, and so on. But this is still a controversial one. I asked exactly the same question a few months ago in the neuro-oncology teaching course to I think Riccardo Soffietti, one of the most prominent expert of neuroimaging in brain tumor in the world. And he mentioned that until now, yes, there are some promising results showing that genomics can probably indicate whether the patients have IDH mutations or not, but it is not yet able to replace the actually examination of the IDH mutation from the patient's biopsy sample. So that's the answer for the second question. And the third question, yes, microRNA is actually currently under development for the treatment, for the diagnosis of glioma. Some are shown to have function as diagnostic markers. For example, MIR21, MIR128, what else? MIR132, MIR210, MIR410-5P. Those are the things that is used to show the higher grade of glioma. And also the microRNA also shown to be able to be used as a prognostic marker. So for example, MIR221, MIR222, and MIR21 are also known to have worse survival compared to patients without increased expression of this microRNA. So yes, there are roles for that, but still, this is still an ongoing study. And until now, not single microRNA has been part of standard treatment. But what is already become standard in the diagnosis and treatment of glioma, according to guidelines, are IDH, 1p19 key codylation, and MGMT methylation. So those three. We don't know whether in the future there will be one of the microRNA that will be part of the standard treatment, but now it is not yet become part of the standard treatment. Thank you, Dr. Eri.
Thank you, Dr. Rusdy. So perhaps if for the blood sample, it's still only for MGMT analysis, I mean, it's only performed in colon cancer, Dr. Rusdy, so not yet in glioma. Perhaps it can be also one of a research idea if you
Yeah, that's possible. That's quite easy to do actually.
Yeah, because it's possible to collect the blood sample of the patients and perhaps to compare with the MGMT analysis from the brain that we already have. Okay, thank you, Dr. Rusdy. I think it's very interesting. But Dr. Andre's questions. Do we still have a question for Professor Matsuo? Yeah. Prof. Matsuo, you still have some questions. This is question from Dr. Arini. The question is that, is there any early diagnosis method for DMD before the symptom occur, Prof? Maybe you can answer the first question first from Dr. Arini.
So as I mentioned, that determination of the serum creatine kinase is a very important clue to diagnose DMD. So if you suppose the patient suffering from muscle weakness, it's better to determine the serum creatine kinase.
Can you screen since the baby?
If not CK determination is available, you can determine the AST and ALT.
Oh, yeah. So
it's strongly elevated in DMD patients.
Yes, thank you, Sensei. So maybe in early years before the symptom develop, the patient can be screened for the level of CK, AST, or ALT, right, Sensei?
Yeah.
Yeah. Okay. Thank you for the question and the answer. The next question is from Dr. Rizka. It's a neurology resident, Sensei. First question is there any correlation between the different genotype in DMD gene and patient's phenotype, such as severity in patients? And the second one is the novelty of DMD therapy. Is a gene therapy already widely used? Any experience in the use of gene therapy, Sensei?
For the first question, DMD is a multi-system disease. So they only show the muscle weakness, but also other phenotype. regarding the muscle phenotype, there are no difference due to the different genotype. But in the case of mental retardation is one of the most common complications in DMD. And mental retardation is commonly identified the patient having mutation in the 3' region. That's there are phenotype and genotype correlation in the case of mental retardation. But in other phenotypes, such as cardiomyopathy, there is no correlation has been identified. Only in another case, sometimes the patient has very mild retinopathy. In the case of retinopathy, we cannot identify that one normally, but if you do electroretinogram, patient shows abnormality. In that case, the patient has a mutation in specific region, but that is not common. But so I can say mental retardation is correlated to the mutation in the DMD gene. That's all.
Yeah, thank you, Sensei. For the second question, maybe Sensei.
No, I have no experience to do gene therapy. Actually, it is understudy in the United States now. But in Japan, no.
Oh, yes.
In Japan, I think antisense oligonucleotide is the most prominent treatment.
Yeah.
Not gene therapy. It's more complicated gene therapy. It's so big.
Yes. Okay. Thank you very much, Sensei, for the answer. Is there any more question for Professor Matsuo, the committee?
I think that's already everything, Ari. But there are some question for Dr. Atitya, I think.
Yeah, we still have a question for Dr. Atitya. It's a question from Neurologi residents, Dr. Ragil. The question is, if we find patients with mutation in gene coding neural sodium channel, SCN1A, is there any impact in the OAE given to patients? Should we consider certain OAE for the patients? Silahkan Dr. Atitya.
Thank you, Dr. Eri. I will answer in bahasa. Ya, Dr. Ragil, ya benar sekali. Jadi mutasi pada kelainan gen ini akan bisa berpengaruh pada terapi. Jadi misalnya di sini gen SCN1A itu akan berpengaruh karena SCN1A itu mengkode natrium channel yang dia akan untuk berperan untuk inisiasi potensial aksi, maka obat-obatan yang bekerja di sana akan terpengaruh. Jadi misalnya pada Dravet syndrome tadi dihindari obat-obat yang bekerja di SCN sodium channel blocker itu, seperti tadi disebutkan bisa yang kuatkan phenytoin karbamazepin atau misalnya lamotrigine. Itu kemudian juga bisa berpengaruh pada respon obatnya tersebut. Jadi dengan pasien dengan mutasi gen SCN1A dikatakan dari beberapa referensi dapat berpengaruh, yaitu dengan tidak berespon terhadap obat-obat tersebut karena terjadi mutasi di channel natriumnya, sehingga obat-obat yang bekerja pada natrium channel itu akan terpengaruh. Seperti itu, Dr. Erio. Ya, tadi menambahkan tadi yang Dokter Adi tadi, mungkin kalau memang masih ada kejang lagi, curiga kejangnya bisa dilakukan pemeriksaan elektroensefalografi atau EEG untuk memastikan apakah ada kelistrikan di otak, seperti itu, Dokter Eri. Terlupa tadi.
Ya, terima kasih sudah ditambahkan Dokter Atitya. Semoga menjawab pertanyaan ya Dokter Adi dan Dokter Ragil. For Dr. Rusdy, do we still have any more questions?
Okay, yeah, I will just answer directly.
Yeah.
Matsuo Sensei is raising hand. Please, Sensei.
I have a question on heart.
Oh yeah.
Yeah. Dr. Atitya, you will have question from Prof. Matsuo.
Thank you very much for your very comprehensive review on mutation in epilepsy.
Yes.
How many examples of mutation detection do you have?
So maybe before she answers, I will give some background senses. So Dr. Atitya is currently undergoing Ph.D. program with the title of Identification of SCN1A Mutations in Epilepsy in Indonesian children, Indonesian patient. So this is one of his part of her PhD dissertation program. So it's currently ongoing. Please, Dr. Tia, maybe you can answer in Bahasa and I will translate it for you.
Maaf Dokter Rusdi, saya tidak terlalu dengar tadi pertanyaannya.
Dia menanyakan sudah berapa banyak pasien yang diperiksa genetiknya untuk pasien-pasien kita, apa yang ditemukan mutasinya begitu kira-kira mungkin.
Baik, Prof. Matsuo, I'm sorry I answer in Bahasa and Dr. Eri or Dr. Rusdi will translate. So, jadi memang belum menjadi kebutuhan, belum jadi pemeriksaan rutin Prof untuk pemeriksaan genetik terutama di neuro dewasa, tapi mungkin kalau untuk neuro anak-anak mungkin saya belum maksudnya untuk detailnya belum tahu apakah sudah dilakukan pemeriksaan rutin. Nah, untuk pemeriksaan untuk genetik pada epilepsi dewasa baru ini Prof. Jadi kami meneliti tentang profil polimorfisme pasien dengan SCN1A dengan dibandingkan antara pasien yang berespon dengan phenytoin dan tidak berespon dengan phenytoin. Nah, itu ada sekitar 120 pasien yang sudah diperiksa SCN1A-nya dan ini baru akan diolah untuk penelitian disertasi saya, Prof. Jadi memang untuk genetik belum ada pemeriksaan rutinnya, Prof. Jadi ini kami juga melakukan pemeriksaannya di lab Dr. Eri di LRT dan sebenarnya dapat dilakukan pemeriksaan di UGM tetapi memang belum jadi pemeriksaan rutin. Nanti mungkin kedepannya akan kami usahakan untuk menjadi pemeriksaan yang rutin.
I will try to translate Matsuo Sensei. So the point is that especially in adult neurology, this is not a part of standard treatment yet. So we do not examine the mutation regularly in patients. But in her study, she is currently having 120 cases of patients that she examined for SCN1A polymorphism. The result is not out yet, so she doesn't know the detail of the profile of the mutations, but it is currently ongoing, but it is not part of the standard examination yet in our country.
Yeah, so I decided to study on Mirafen.
Oh.
Mirafen is developed in the United States to treat the epilepsy for one patient.
Yeah.
So that's the example to apply for mutation analysis to clinical.
Yeah. By the way, Matsuo Sensei, Dr. Christy asking one question in the chat group. If you can,
I think Dr. Christy can directly ask her.
If maybe...
Please, Dr. Christy.
Okay. Okay. Thank you, Dr. Eric. Good evening, Prof. Matsuo. This is Christy. Could you hear my voice?
Yes, we can hear you.
Okay, thank you, Dr. Rusdy. So, Prof. Matsuo, I would like to ask about your statement that the mutation on the 3N have mental retardation. So that is my thesis actually right now. And we found also that in Indonesian background, it is also the same that those who have mutation at the 3N has the lowest IQ score. But from what I read, that it is also not only mental retardation, but also autism and hyperactive disorder, ADHD, attention deficit and hyperactivity disorder. but we don't found that correlation in Indonesian patients. Could you maybe comment about that? What is my did I do wrong in diagnosing the patient with autism and ADHD in my thesis, or is there any other explanation? Thank you.
Yeah, the summary of the question is also already on the screen, Sensei.
Yes, you can answer the question, Sensei.
So it is one of the complications of DMD. So I suppose that the patients should have the mutation in the 3' end of the DMD gene. Did you identify mutation in that case?
Yes, Sensei, we do the MLPA and also exome sequencing to identify where is the mutation is. So we divide our patients into 3 groups: the 5N, the middle mutation, and the 3N. And we found that those who have mutation in the 3N has the lowest IQ score, mental retardation.
I'm sorry, I cannot hear you.
Yeah, they found that the patients with mutation in the 3'N location has the lowest IQ score, but they don't find correlation between mutation location with the autism and hyperactivity disorder. So what do you think about that results?
So she identified the mutation in 3' end.
Yes, she did identify the mutation. So they did find the correlation for the 3'N mutation and mental retardation. Yes.
Yeah.
But they don't find the correlation between autism.
That's a good correlation.
Yeah.
Yeah.
How about autism and hyperactivity disorder, Sensei? Do you have patients with that symptoms also? Do you have patients?
I can't hear you.
Do you have patients with autism and ADHD also?
Autism.
What syndrome?
Autism, Sensei, like it's shown in the screen with autism and ADHD. I think we have some kind of signal problem.
Sorry, I cannot hear you.
Maybe we will questions privately, Dr. Christy.
Thank you.
Yes, we will deliver the question and convey the questions to him. Yeah. Thank you, Dr. Christy. Prof. Matsuo. I think the last question is for Dr. Rusdy. We will answer. Dr. Rusdy, please answer the last questions, and then we can wrap up the discussion session, and then we can take a picture together.
What is the last question?
Please share the last question for Dr. Rusdy.
I think I finished. Oh, okay.
You haven't answered.
Significant difference between therapy MGMT method. There is significant difference. If you see the NCCN guideline clearly in the end part of the treatment, if the patients have methylation of the MGMT gene, there is place for temozolomide only without radiotherapy. If the patients cannot get radiotherapy, or for whatever reasons they cannot have radiotherapy, you can consider temozolomide chemotherapy only. But that kind of treatment is not possible in patients without methylation of the MGMT gene. And in the newest guideline of EANO in 2021, if the patients have with anaplastic astrocytoma without methylation of the MGMT gene, with methylation of MGMT gene, they will not do concurrent chemoradiotherapy. The temozolomide will only be given as an adjuvant treatment. So there are some significant difference there. There are good outcome on phosphoric acid. All right, so this is old evidence. The newest evidence with larger sample size in newer trials didn't show any difference between patient receiving as valproic acid with patient receiving other type of anti-epileptic drug relating to the tumor treatment. So you define the medicine given to the seizure based on the evidence needed for the type of seizure. So you don't give them in the purpose of actually improving the tumor, because until now there are no evidence whether levetiracetam, valproic acid, or perampanel have evidence to improve the tumor itself. So until now we don't give valproic acid for improving the tumor, we give it only for controlling the seizure. And because of that, the dose will be similar with other valproic acid dose in other type of epilepsy. So that's my answer for second questions.
Thank you, Dr. Rusdy, for the answer. Okay, I think we have finished all the questions, right, committee? And then we can take picture together for all participants who able to activate your video. Sensei, do you have any question? Yes, Sensei.
I have a question.
Oh yes.
To whom, Sensei?
To who, Sensei? To who?
So, Rusdy, I
Yes,
have a
yes.
question on
Wait for you.
Okay.
You show the outcome of the patient
Yes.
with glioma.
Yes.
When the patient have a mutation in IDH,
Yes.
the outcome is good
Yes.
compared to non-mutated one.
Yes.
Right?
Yes.
So that means that mutation induce a good outcome.
Yes. The mutation induces good outcome. Yes, Sensei.
So, right? Good mutation contributed to provide a better outcome.
Yes, Sensei. So this is very special for IDH mutation. So IDH mutation will cause formation of glioma, but in the same time, the glioma will also be more moderate. The characteristic will be milder compared to the one without the mutations. And the second one, the mutations will respond better to chemotherapy and radiotherapy. So that's why the prognosis is better. So the mutation cause glioma formation, but because of the mutations, the patients will respond well to chemotherapy. So that's why the prognosis is better if the patients have the mutation. Yes, Sensei.
You know, usually mutation disrupt the function of the gene.
Yeah, that's true, Sensei. But in this case, because of the mutation, we can treat them. So we can treat the problem. But if there is no mutation, we don't have the target for treatment. So that's why the prognosis is better, because they will respond better to treatment. Because the IDH mutation will cause the instability of the cells. That's why if we give chemotherapy, the cells will die faster and better. So that's why the patients will respond better to treatment of chemotherapy, which is not the case in patients without the mutation. The stability of the cells will be better, so that it will be very difficult for chemotherapy to actually work. So that's why the difference is quite consistent if the patients get treatment.
Okay, thank you.
Thank you, Sensei. I
Thank
think it's
you.
picture time.
Yeah, sure. Please activate your video if it's possible. Yang memfoto siapa ya, Dr. Andre?
So we'll have photo session, Sensei.
Ya, mungkin Ibu beri aba-aba.
All right, in the count of 3, we will take picture.
Okay, let me begin the photo session in 1, 2, 3. Okay, maybe once more. 1, 2, 3.
Okay, thank you, Dr. Andre. So I think we already wrap up our discussion. Thank you very much for all speakers for the enlightening lectures and also fruitful discussions. Thank you so much also for the committee for the hard work, and also for the all participants for joining our international guest lectures. I hope it will give benefits to all of us, and see you again sometimes, maybe in other occasions. So thank you very much, and I close the sessions. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh. Arigatou gozaimasu.
Thank you.
Thank
Thank
you.
Thank you
you.
very much, Sensei. Arigatou gozaimasu.
Terima kasih.
We hope we can visit you next year, Sensei.
Thank you.
Thank you.
Thank you, Prof. Matsuo, Dr. Rusdy, Dr. Eri.
Thank you, thank
Thank
you.
you, Dr. Tia.
Thank you. Bisa di-end mungkin, admin?